Well, thank you for the very kind words in the introduction, and thank you for taking out the time to come. I understand that everybody has a very, very busy schedule, and to take out the time from your work or your family or personal life means a lot. So hopefully your time spent here will not be wasted. You kind of got my introduction already, so I'll start with my presentation. But before I do that, I want to thank many people who have played a big role in putting this evening together. The list is long, and I apologize if I missed any, but physicians who, again, from their busy practices have taken out the time to say, you know what, we need to make this a St. Michael event to get out in the community and bring people together around a very important topic, which is the current epidemic of obesity. I would like to thank Dr. Bani, Dr. DeCosta, Dr. Sensikovic, who've taken out the time to call, and Dr. Shamoon, of course, to call other physicians, because I'm new to this area in the field of practicing medicine, so I don't even know half of the people here. So thank you for coming. Without any further ado, I would like to start the presentation. I thought of the title very deliberately, and I think it's very appropriate for the present time. Let's unite in the fight against obesity. Obesity has spread like wildfire right underneath our noses and is affecting each and every one of us, whether we are part of the healthcare community or not. And because it's really spread like wildfire, the way to approach it is nothing less than putting up a fight. And the only way we can do that is if all of us come together. I think this is a beautiful example of how medicine and surgery come together. Throughout my surgical training, it has always been like the medical docs are separate and we just focus on surgery. And I'm grateful that I'm in a field that requires meshing of medicine and surgery together for the betterment of our patients. So why are we here today? Obviously because of obesity. I'm going to address some facts and myths. How can we help our patients? That is the bottom line. And how the Metabolic and Bariatric Center at St. Michael's can help you achieve that goal for your patients. So why are we here today? This is a busy slide because there is a lot of good reasons why we are talking about obesity being the pandemic, in fact. I don't know if any of you guys can see the numbers. The bottom line with this slide, I'm just going to move this here so I'm not blocking anybody, is that the National Nutritional Examination Survey, which is NHANES, suggested that obesity affects 35.8% of the women and 35% men, and children of 16.9% of children between the age ranges 2 and 19. If you think about that, that's a very big number. In December of last year, 6 months ago, there was another study published which said that 25% of the children in North America are overweight, which means their BMI is greater than 29. So when you think about the disease of obesity, how it's progressive, it's lifelong, and it only gets worse. So we are essentially raising a generation of children who are going to feed into the supermorbid obese category. For all those, just to refresh the memory of what supermorbid obese is, BMI greater than 50, 50. And there is a slide in a few minutes. I'll break down the BMI classifications for you. Obesity is a disease. And this is what I tell my patients also, that they have to literally let that word disease sink into their minds, just the way you address the disease of the heart or the kidneys or the feet. It's a disease, and it has to have the same attitude. And I would request the healthcare professionals to also look at it that way. There's been a lot of data on what are the factors that have played into not enough people reaching out to bariatric surgeons to seek out the treatment for obesity. And one of the factors that came out was the communication or the starting of the conversation between the patient and the primary care physician. 70% of the patients, and this is a study that's been published, it was out of Ethicon Endosurgery funded that study, it was based out of a program in Texas, that 70% of the patients said that we wish our primary care physician had started the conversation of obesity. Now, unfortunately, there is a social stigma associated with your weight. When you look at weight as just equal to how you look and the size of your clothes, yes, there will be a social implication. But when you think about it as a disease, then it eradicates that social discomfort for the patient or the family member. And once you have that mindset, then I think everything else kind of falls into place. Whether the patient or the family member needs that extra push, we can link it by justifying how obesity is a disease in so many ways. And I'm going to be focusing on 2 or 3 of the different aspects in a few minutes. How do we measure obesity? Currently, our measure is BMI, body mass index. It's not the perfect tool, but it's the best tool that we have. It standardizes weight. 300 pounds in a 5'1" female is very different than 300 pounds in a 6'3" male. So you have to keep in account the gender, the height. And BMI helps to manage that. Now, that's not the best tool because you should look at the medical comorbidities along with the BMI. But for literature purpose, for studies purpose, for insurance companies purpose, BMI is a great tool. The acceptable range for the BMI is between 18.5 up to 25. And anything above that, then you can subclassify that into worsening stages of obesity. So just the way I alluded to in a few minutes ago about where does super morbid obesity fit into, this table will hopefully help explain that. So the overweight is 25 to 29.9, obese is 30 to 34.9, severe obesity is 35 to 39.9, and then you can see that super morbid obesity is greater than 50. Now, if the patient has one medical comorbidity, like high blood pressure, and the BMI is 35, they fall into the morbid obese category, which is why it's not just clear-cut BMI. The medical comorbidities do elevate the significance of that weight and the urgency to do something about it. Now, I will take a minute just to talk about the NIH census that came out in 1999, so many, many years ago, almost 20 years ago, and that was the basis of insurance companies saying that they will only approve bariatric surgery if the patient is morbidly obese, which means BMI greater than 40 or BMI greater than 35 with at least one comorbidity. Now, it's been 20 years is a long period of time. There's a lot of evolution in terms of our understanding of the disease, the comorbidities. There's so much more data coming out in the role of bariatric surgery in the resolution of diabetes, for example, and that's the basis of the term metabolic surgery. So we need to revisit these guidelines and change them. And the first step, I guess, in that direction was when the FDA approved the gastric band for BMI 30 and above. And I right now know that ASMBS, which is the American Society of Metabolic and Bariatric Surgery, is working on a white paper to change the whole criteria for bariatric surgery and basically start from BMI 30 and above. Because we have more than enough evidence to support how early intervention translates into life expectancy. So BMI between 25 and 30 versus 30 and 35. Just looking at that group of patients. And so this is not morbidly obese. We're just talking about overweight and obese. If you intervene in the BMI 30 to 35 and you compare their life expectancy to the group which is BMI 25 to 30, you're saving 3 years in terms of life expectancy. That's huge. 3 years. So that's going to be the basis of them pushing for the criteria to be changed. And